All right, let's jump right into a classic Viva scenario. So picture this. A 7-year-old boy walks into your clinic, he's got a limp, but he tells you it doesn't hurt. Now, that's a pretty common presentation, right? And your differential is going to be broad. But today, we're going to zero in on one really important diagnosis, Legg-Calvé-Perthes disease.
Welcome to The Explainer. Today we are tackling Perthes disease, and we're going to do it in a way that'll get you ready for any clinical question that comes your way. We're going to follow the entire patient journey, really focusing on those critical decision points, from that first diagnosis all the way to the definitive treatment. So here's our game plan. First up, what does a patient actually look like clinically? Then, how do we use imaging to figure out what we're dealing with? We'll cover the goals of non-operative care before we dive into the main surgical options. And finally, we'll wrap up by looking at the long-term prognosis and what complications to watch out for.
Okay, section 1, the clinical presentation. So what are those first few clues that should make you think, this could be Perthes?
So, at its very core, Legg-Calvé-Perthes disease, or LCPD for short, is what we call an idiopathic avascular necrosis of the proximal femoral epiphysis. Now, that's a mouthful, but in simple terms, the blood supply to the ball of the hip's ball and socket joint just gets disrupted. This means the bone cells start to die, and if it's not managed properly, that femoral head can actually collapse and become deformed.
Your typical patient is going to be a boy. We see it about 5 times more in boys than girls, usually somewhere between 4 and 8 years old. And the onset is often really sneaky. They just kind of start limping. Here's a clinical pearl for you. If there is pain, it might not even be in the hip. It can be referred down to the groin, the thigh, or even the knee, and that can really throw you off the scent. On your exam, the absolute key finding is a loss of motion. Specifically, you have to check for a block in internal rotation and abduction of that hip.
Okay, on to section 2, imaging and classification. So once you have that clinical suspicion, the next step is to actually see the problem. And imaging isn't just going to confirm your diagnosis. More importantly, it's going to help you classify just how severe the disease is.
So you're going to start with AP and frog leg lateral x-rays of the pelvis. Now keep in mind, in the very early stages, these x-rays might look totally normal. What you're looking for are these subtle signs, things like a widening of the medial joint space. Maybe the femoral head looks a little smaller or more dense, what we call sclerotic, or this absolute classic finding, a subchondral fracture which shows up as the crescent sign.
Radiographically, the disease actually moves through 4 distinct stages, which we call the Waldenstrom stages. It starts with that initial stage of infarction, then it moves into fragmentation as the blood supply tries to return. After that comes reossification where new bone forms, and finally the healing stage where that femoral head remodels itself until the child is done growing. Understanding these stages really helps you track the disease over time.
Now, let's talk classification systems, because this is a huge point for your exams. For a long time, the Catterall classification was the standard, and it's based on how much of the head is involved. But look, the modern evidence is really clear. The Herring lateral pillar classification is superior. It's not only a much better predictor of the final outcome, but it also has significantly higher reliability between different surgeons. So this is the one you really need to know.
The Herring classification is all about the height of the lateral pillar of the femoral head, and you assess it during that fragmentation stage. A Group A hip, where the pillar is full height, has a fantastic prognosis. On the other end, you have a Group C hip, where less than half the height is left. That's a poor prognosis. And it's this very classification that is going to directly guide your treatment decisions. All right, section 3, goals and non-operative care. So we've got our diagnoses, we've classified the hip. What are we actually trying to accomplish here? And, more importantly, when can we get away with not doing surgery?
Our goals are pretty straightforward. First, relieve any symptoms. Second, restore the hip's full range of motion. And third, and this is the big one, we need to contain the femoral head within the acetabulum, which is the hip socket. This idea of containment is the absolute cornerstone of treating Perthes. Basically, you want that hip socket to act like a natural mold for the soft, healing femoral head, guiding it to heal in a nice, round shape.
So when is it okay to just watch and wait? Well, observation is actually the go-to treatment for younger kids. We're talking a bone age under 6, or chronologically under 8, and for any child with a Herring lateral pillar Group A classification. Treatment is simple. Restrict high-impact sports, get them into physical therapy to maintain motion, and keep a close eye on them with regular follow-ups. And what's really important to remember is that in these specific groups, we can expect a good outcome in about 60% of cases without ever having to go to the operating room.
And that brings us right to section 4,
What about the children who don't meet those criteria for observation? The older kids or the ones with more severe disease? Well, for them, we have to think about surgical containment. And the real workhorse procedure here is the femoral varus osteotomy.
Yeah, just like Diab and their colleagues summarized back in their 2020 review, the proximal femoral varus osteotomy, or FVO, is still the most commonly used and reported surgical option in all the literature. It's got a long track record and a ton of solid evidence behind it.
So what exactly is an FVO? Well, the main indication is a child over 8 years old with a more at-risk hip, like a herring lateral pillar B or B/C. What we do is we actually cut the femur bone just below the hip joint and change its angle. The whole goal is to better seat or contain that femoral head inside the acetabulum. But it's not a perfect solution. It does have its downsides, namely that it can shorten the femur and potentially lead to a limp or some abductor muscle weakness.
And the evidence backing this up is really strong. There was a landmark study by Wieg and colleagues, a prospective study of 368 patients, that really provided the proof. What they found was that in kids over 6 with significant femoral head necrosis, an FVO was way better than non-surgical treatment for preventing deformity. And that's the kind of high-quality evidence you need to be quoting.
Okay, on to Section 5, Alternative Surgical Options. So, FVO is our main go-to, but what other tools do we have in our surgical toolbox for those specific salvage situations or really special cases? While the varus osteotomy is our primary tool, a key alternative for a totally different situation is the femoral valgus osteotomy. And it's so important you understand this. It is not for primary containment. Think of it more as a salvage option for a late-stage complication called hinge abduction, where a deformed part of the head is kind of jamming on the socket. The valgus osteotomy can reposition the head, improve leg length, and fix those abductor mechanics. Now, beyond just cutting the femur, you can also address the socket side of the joint. We've got pelvic osteotomies, like the Salter or shelf procedures, which are designed to improve the coverage of the femoral head from the acetabulum side. And then, for very specific cases, there's the transtrochanteric rotational osteotomy, or TRO, which is a really complex procedure that rotates a healthy part of the femoral head into the main weight-bearing part of the joint. And finally, Section 6, Complications and Prognosis. Let's talk about the long game. What can go wrong down the road, and what are the key things that determine the ultimate outcome for these kids?
The shape of that femoral head when the child is finally done growing is the single most critical factor. If it's deformed, say it's too wide, which we call coxa magna, or too flat, coxa plana, that can cause a whole cascade of problems. Things like the growth plate closing too early, leading to a short femoral neck, or the hip socket not developing properly, and of course labral tears. But the number one long-term worry, the thing we're really trying to prevent, is the development of early degenerative arthritis later in life. So let's just boil this all down to the most important prognostic factors. If you remember nothing else from this talk, remember this. The single most important indicator for a good long-term outcome is the patient's age when the disease starts. A kid who's diagnosed under the age of 6 has a much, much better prognosis, and that's simply because there's more time for that femoral head to remodel and heal. After age, the final roundness of the head and the initial herring lateral pillar group are the next most important predictors. And that brings us to our final and maybe most important question. The evidence gives us a really clear framework, right? It's based on age and what the x-rays look like, but medicine is so much more than a flowchart. So how do we take all this data and apply it to the individual child and family sitting right there in front of us? Balancing this solid evidence with their preferences, their lifestyle, and their goals, well, that's where the true art of being a doctor really lies.